everyone. Welcome to Empowering Exceptional Minds, the podcast diving into neurodiversity through real conversations with parents, individuals, and professionals on challenges, strengths, and unique experiences. I'm your host, Mayan Glazer-Corin, educational therapist, ADHD educator, and ASD certified specialist. At Educational Therapy LLC, we support kids and adults with executive function and learning differences toward confidence and independence. This podcast collaborates with WIS Therapy, connecting individuals to providers and streamlining services for neurodiverse communities. Our goal is to share strategies, stories, and insights to empower families, educators, and professionals. This podcast is for informational, educational purposes only and isn't medical, psychological, or legal advice. Consult professionals for concerns. Guest views are their own, not necessarily the host's or WIS therapies. By listening, you agree neither host nor guests are responsible for actions based on this content. A quick note, for concerns about well-being or mental health, contact a doctor or professional in your area. For emergency, dial 911. Crisis text line, text 741-741 anywhere in the United States. All right, today we're joined by Dr. Sutton, a licensed psychologist and the director of the Institute of the Advancement of Psychotherapy. Dr. Sutton is a very busy person, but I'm so happy he agreed to do this interview and to be our guest speaker because he has a lot of knowledge and it can help many of us professionals and parents and educators. Dr. Sutton, please introduce yourself.
Yes, hi. Well, thanks for having me on. Yes, I'm a psychologist in the San Francisco Bay Area, and particularly I'm the director of the Institute for the Advancement of Psychotherapy, where we have a group practice of 27 therapists throughout the Bay Area and also providing services throughout California via Zoom, as well as psychiatrists. And then I'm also the director of our associated nonprofit Bay Area Community Counseling, where we have associates who are seeing folks on a sliding scale to meet financial need, and who are getting training in the evidence-based approaches that we're using, family systems, emotionally focused couples therapy, eye movement desensitization, reprocessing, and cognitive behavioral therapy. And we connected through our Bay Area Center for ADHD, which is one of our specialty centers. And we just actually celebrated our 15-year anniversary last month. We've been providing services for children, adolescents, adults, couples, and families with ADHD for many years now.
Wow, congratulations.
Thanks.
15 years. That's a long time for helping many families.
Yeah,
Thank
definitely.
you.
There was not a lot of services back then for folks with ADHD, and oftentimes there was a lot of misunderstandings around ADHD. So we use evidence-based practices and are guided by research and so on, and what's effective.
Yeah, you just mentioned the misunderstanding about ADHD. Do you mind to expand a little bit more about that? What did you notice?
Yeah, I mean, I think that, and it still persists today, that
Right.
times people are like, oh, everybody has ADHD or something
Right.
like that, or they'll just outgrow it, or it's just, bad behavior. They're just being lazy or whatever it might be. Or a lot of misunderstandings around, it was caused by trauma or something, or it's, the medication is not effective, or you need some sort of brain scan to determine if it's ADHD, or take supplements, or eat a different diet, or all these different kind of things. So there's a lot of confusion out there, and still to this day, there's even some recent articles in the New York Times with a lot of this information that's not really backed by evidence. I'm driven a lot by Dr. Russell Barkley's work, and he has really kind of one of the leaders in the ADHD field on the research. He's also wonderfully in the last few years put all of his trainings on YouTube for free for everyone to have. He's just recently actually finished and retired. He used to do weekly updates on research, but it's a great resource for folks that want to learn more and also the evidence base behind ADHD.
He's fantastic. I also did training with him, and I love the fact that he's not sugarcoating anything.
Yes.
And people needs to hear that. I mean, people
Mhm.
needs to hear why the medication exists,
Mhm.
why it helps.
Mhm.
I mean, I work with clients with and without, and you see the tremendous progress when they're on it. I always tell it to families that are kind of hesitate to do their homework. And I also refer them to Dr. Russell Barkley's work. And also to have the understanding, it's like not giving a child insulin, right? If it's
Mhm.
diabetic or not wearing glasses.
Mhm.
So this is how I kind of like to help parents understand. At the end of the day, it's the family decision. Um, I've been, talking in this podcast a lot about the effective and the benefits of the medication. And yes, they do have side effects, and you need to talk with your pediatrician. But there are so many medications out there, and they exist for so many years. It's not that there was no any research about them.
Mhm.
We're not just giving them for no reason. And this is something really important. And it's not because we want to put the kids in a box. No, it's
Yes.
because they need the help. It helps with regulation. Maybe you can talk more about it, about what do you see with meds.
Sure. Well, let me talk a little bit about my conceptualization of ADHD, and then I'll talk about how the
Uh,
meds play in.
Absolutely.
Yeah, so with ADHD, there's less activity in this part of the brain. I'm touching kind of my forehead where the prefrontal cortex is. There's a number of other aspects that are also affected, but this is kind of one of the main areas. And this part of our brain is in charge of three major pieces. One, it's the mental stop button. It's the part of our brain that says stop, don't interrupt, stop, wait your turn. Also for the hyperactivity, impulsivities, to stop and sit still. It's actually our natural state is to be hyperactive and moving all around. That's why all preschoolers look like they have ADHD because their frontal lobe hasn't developed yet. It's also the part of our brain that says stop, focus on what you're doing rather than paying attention to what's going on over there. And so it's not that folks with ADHD can't pay attention, it's that they're paying attention to everything all at once and having a hard time inhibiting the impulse to pay attention to one thing and focus on another. So the way I describe it is kind of like juggling. So in our working memory, that part of our mind where if somebody gives you a phone number to remember and you're kind of running it through your mind, that's our working memory, which then we move it into short-term and then long-term memory, but we can hold 7 items plus or minus two. So it's kind of like the person is juggling these 7 balls, and then the world is kind of throwing other balls at them. So if they kind of look over here or they go to grab that one, they drop all the under balls, and so they only are left with two or three. For folks without ADHD, it's almost like they can put up a plexiglass window and all those balls are bouncing off and they're able to focus on what they're juggling. But if they're sick or they haven't been getting sleep or they're really stressed out or they're spread too thin at work, that wall is also going to come down. That's why everybody has experienced difficulty with attention from time to time, but it's whether or not it's been consistent and throughout the lifetime, particularly prior to age 12, that we're looking at whether it's ADHD. So that's the first piece. The second piece is that this part of the brain is also in charge of getting started on things, or what's called initiation, as well as stopping and switching. And so for many folks with ADHD, they have a hard time getting going on tasks, especially if it's not very stimulating task. And then on the flip side, things that are very stimulating, they have a hard time stopping and switching. So for example, a kid that is, you're struggling to get them to do their book report, but then they can play video games for hours and look very focused. Or your adult who is having trouble getting their taxes done, but they're scrolling on TikTok for hours and are very focused. And that's the variable attention. And so one of the aspects of the diagnosis is starts things but doesn't finish them. And this is because oftentimes when we're starting a new project, it's exciting, we're really into it, we're really motivated. But then when it comes to kind of finishing it up or cleaning up, crossing the T's, dotting the I's, that's not as interesting. So oftentimes things get left halfway, three-quarters done, or so on. And then this is also where procrastination comes in. Oftentimes the person has a hard time getting going, but then sometimes at the last minute, the anxiety actually kicks in that frontal lobe and they get it done at the last moment. And then the third piece is this part of the brain is in charge of organization, looking at time and time moving forward. breaking down larger steps into smaller steps, our kind of visual-spatial memory. And all three of these aspects are affected by ADHD. And Russell Barkley talks about the 30% rule, how folks with ADHD are behind 30% on average in the executive functioning abilities to others their own age. But this has nothing to do with intelligence, which is actually one of the most frustrating things for kids, adolescents, adults with ADHD, because there's a disconnect between the how and the what. The person knows what they're supposed to do, they just can't put it into action in the moment. So the kid that's going out to play with their friends, they, impulsively run out the door and leave the door unlocked, or they, are not paying attention. They leave the door open, and the parent says, "Hey, you got to close the door." And they're like, "Oh, I know, I'm not stupid. I just didn't do the thing I know I need to do." And so that's where one of the key pieces with ADHD comes in, which is shame. And particularly for adults with ADHD, that's one of the biggest struggles, because, right, there's this sense of like, I should be able to do all this stuff, but I'm not doing it. What's wrong with me? And so in working with children and adolescents, I often talk about with parents, one of our goals is to help them get through their childhood without a great deal of shame. And then for the adults that I work with, it's really, learning how to understand ADHD, how to outsmart it, because by definition, the person's going to mess up 1.5 standard deviations more than the average person. So, of course, we can decrease the mess ups, but we really want to build that resiliency where the person's able to get back on track, keep going, face whatever things have gone wrong because things went off track, rather than going into a shame spiral and just avoiding and letting things just kind of snowball.
Yeah, and the self-compassion aspect
Yeah.
is crucial. I also hear, because, in my line of work, I see them, sorry, when they are not initiating, right? And we do see this procrastination, and we do see all those things. And, when you have this like phone call with the parents, it's like, oh, they're not motivated. And sometimes they use the word lazy, which is not allowed in this space.
Sure.
And and also the word should, could, would. So I don't allow, I mean, I catch my clients on, this like self-talk, all the parents. So yeah, motivation is a big aspect of that as well. And I always tell my clients that motivation is a crazy monkey trying to go on a surfboard. Because it comes in surges, and
Yeah.
you can be like, yeah, I'm gonna go to the gym today, right? I'm gonna do the gym every day. I'm like, so we also have to be realistic and kind of understand, awesome, that you want to do it. Or you just mentioned the fact that they are stopping in the middle, and I'm thinking about the adults that we work with. They want to organize, let's say, their closet, take everything out, KonMari style, and Marie Kondo style, sorry. And then like a few minutes later, they're like, it's too much. They're overwhelmed.
Yes, yes.
So it's like what you said, the importance of like those tiny steps are crucial. You don't need to do your entire closet, just do maybe a drawer.
Yeah, exactly. Yeah, kind of
Yeah.
breaking into those smaller parts. And particularly your question earlier was about
Yeah, the
medication,
meds.
how that works. And so I'm a psychologist, so I don't prescribe medication. But I really recommend medication and medication evaluation because the research supports it significantly. And Russell Barkley talks about it would be even malpractice for a clinician to not recommend medication due to its effectiveness. We can talk about, the research and so on, but medication in combination with cognitive behavioral therapy with adults and family work with the children and adolescents is the most effective
Yep.
treatments for ADHD. And particularly, it's increasing the activity in that frontal lobe, so the person is able to inhibit those impulses, sit still, inhibit the impulse to focus on the conversation in the other room and focus on the conversation that they're having. Also being able to get started on things, as well as stopping and switching, and also the executive functioning pieces. That's where it comes in a lot with the organization, the time management, breaking down tasks, and so on. But the medication oftentimes helps a person slow down enough to be able to put those into action. And medication doesn't work for everybody. And I work with folks that aren't interested in using medication. But yeah, they are one of the safest medications out there because they've been being given to children. There's long-term studies. The biggest side effect is a few centimeters difference in height because oftentimes it suppresses appetites for kids. So usually I talk with the kids and the parents and the adults about talking to their psychiatrist or their pediatrician or general practitioner and trying to get the highest dose that is the most effective with the lowest side effects. Because if the dosage is too high and there's too much side effects, it's highly likely that the person's going to stop using the medication. And so you lose all effect. But the side effects from not treating are so significant. Physical accidents, earlier drug and alcohol use, for girls, earlier self-harming, issues around health, weight, smoking, all these things affect folks with ADHD. So, and the medication has been found to be helpful in actually preventing those difficulties and actually helping to mediate those difficulties.
It's interesting you mentioned that. My friend, she's a cardiologist, and she works at Stanford. And one of the things that she said is that she does see a correlation between ADHD and cardiovascular diseases.
Mm-hmm.
I didn't get into a research, so I would love to read more about that. So
Yeah.
that's gonna be interesting. But you do see that. I mean, you do see some health issues coming up as well. I also read about research about dementia can be, without treatment of ADHD meds, can be affected because it's a memory. But
Mm-hmm.
I'm sure there is more to it, like also, what we
Yeah.
eat, we move.
Well, I
We
would
have to
say,
work our brains.
yeah, and I would say going back to the research on ADHD,
Mhm.
and particularly, the Russell Barkley addresses a lot of the issues related to cardiovascular issues
Right.
and talks about that there is a slight increase for folks. There's also a number of confounding factors. Oftentimes the people that are on medications, been on medications longer, oftentimes have a more severe ADHD, as well as all the other complicating factors related to ADHD, smoking, drinking, overeating, and so on, which also are going to affect heart health. So I would definitely recommend for folks to check that out. Many psychiatrists, especially with adults, will monitor blood pressure as they're also, going along with treatment just to be safe. And so those are also definitely things to check out and talk with your general practitioner or your psychiatrist about if you have any heart issues or concerns.
Yeah, these are really good points. It just really eye-opening how much you know with research, if we do our homework and we read, it can really help us understand and do like prevention, right?
Mm-hmm.
Okay. The reason I also wanted to talk with you today, also because you're a very nice person, but also because I'm really interested because you guys also do evaluations,
Mm-hmm.
and I'm just interested if you can share what a comprehensive ADHD assessment typically includes.
Sure. So there's a lot of confusion with folks around assessments, who can do assessments, and some assessments are done by pediatricians.
Right.
And actually, in Steve Hinshaw's work, he talks about that they've actually done some research and found that diagnosis are tend to be done in about 10 to 12 minutes of a visit, and also having fill out just some symptom questionnaires about the ADHD diagnosis symptoms. Or some people are going and doing full neuropsych evals that are taking, 10 hours of testing, writing up this 50-page report, and so on. But those are the extreme ends. What's most important is one, doing a good clinical interview and figuring out, is this ADHD or is this anxiety, depression, bipolar, trauma, and really getting that history, because on any of the neuropsych measures, we can say, yes, there is a problem with working memory, or there is a problem with reading speed, or so on. But then we have to look at, what is the cause of that? Is that depression? Is that anxiety? Is that ADHD? And that you all have to go to your clinical interview. There's no test that's going to say, yes, this is ADHD, or no, this is not ADHD. So that's one of the most important parts, the clinical interview, and of course with the adult themselves or with the parents, as well as the child and adolescent. For the younger kids, we're also going to get multiple sources because ADHD needs to be present in multiple settings, not just at home, but not at school, or not just at school, but not at home. So we're usually going to talk to the teachers. We're going to review report cards. And even when my adults that are coming to me, sometimes in their 30s, 40s, I ask them to check if their parents are still alive with if they have any school records. And you'd be surprised how many people do. So really getting to look at that, because particularly those elementary school years are really important in determining whether or not those symptoms were present. So we're getting the clinical interview, we're getting, multiple different reports, and then we're also having them fill out a symptom questionnaire that is normed for gender as well as age. Because the way that ADHD was developed, that diagnosis, is that when the symptoms 6 out of 9 were present, it put the child at the 93rd percentile, 1.5 standard deviations above the mean. So that little 7 percentile, if we kind of think about that bell curve, is what is ADHD. And all of us have, difficulty with attention concentration at times. Some people have much less, some people have much more. So this is a trait that everybody has. It's when, again, that it's 1.5 standard deviations more than the average person, that's when we get the diagnosis of ADHD. And what also happens is the symptoms change over age. We don't have many adults coming in saying, oh gosh, I can't stop running around on the couch at home, because our frontal lobe is developing over our lifetime until our brain finishes development, 25, 30 years old. And so the ADHD symptoms are going to change over time. And with adults with ADHD, the 93rd percentile is when there's 5 out of 9 symptoms, or sorry, 4 out of 9 symptoms of ADHD, although the DSM is placed it at 5 out of 9 to diagnose ADHD in adults.
Interesting.
And so we're doing the clinical interview. We're also getting other reports. And I should also mention too, with all the adults that we do evaluations with, we also talk with their parents if their parents are alive. Because again, those childhood symptoms are the big differential, because the frontal lobe is the first thing to go when we're dealing with depression or anxiety or substance use disorders, all these kind of things. So again, getting a report on what things were like in those elementary school years. And some people say, oh, the parent's not going to remember. And I've talked to parents in their 80s, and one mom said, the nuns used to say, oh, Miss So-and-so, you must be a saint. If it's really ADHD, oftentimes folks are not going to forget. So clinical interview, multiple sources, as well as the symptom questionnaires filled out by the person as well as others, to compare their symptoms to others, their age. And really, that is what is the gold standard for diagnosis of ADHD. And that doesn't take very long. That can be over a few sessions. Now, if we want to get into the full psychoeducational evaluations, you can do the IQ testing and get cognitive abilities. We can look at academic achievement, because particularly with folks with ADHD, there's a 50% comorbidity rate where folks with ADHD also have learning disabilities. So we want to be able to determine, do they have dyslexia? Do they have dysgraphia, dyscalculia, any of these learning disabilities going on? Usually we can screen and, get information about that to determine if we need to go farther into it. We also might need to do testing to look at, rule out developmental disability. Also autism, whether or not that's comorbid or that's what's accounting for of the ADHD symptoms. And in the beginning, I was trained to do the WAIS or the WISC, which is the IQ test, the WIAT, the academic achievement, the WIAT, and then also the, I was doing the DCAFs, the Dells-Kaplan executive functioning scales, the RAML, the wide range assessment of memory and learning, all these different tests, because I felt like I was cracking the code. But I oftentimes was finding that I didn't get much more than I got from my clinical interview and questionnaires. And, again, so much is influenced by Russell Barkley's work, right? And the research doesn't support using that testing. And actually, particularly in cognitive performance tests, which are oftentimes used with ADHD, where they're supposed to kind of click on a button when they see a certain thing, but not click at other times. The research has actually found that if it does say, yes, there is a problem, then again, we have to go back to, is it depression, anxiety, trauma, ADHD, all again, back to our clinical interview, but also it misses the diagnosis about 50% of the time, because one of the issues with ADHD is what's called variable attention. Sometimes the person can be very focused and even hyper focused. Other times they're having a hard time engaging or being focused at all. And so you may not know what you're getting day to day, depending on where the person's at. And usually the testing is in a quiet, distraction-free room and so on. So oftentimes I've heard of people saying, no, this is not ADHD, despite all the evidence, because one or two tests is not showing that significant difference, which is really not a great way to do it. And again, on YouTube, Russell Barkley goes through all the research around testing and such, and how the neuropsych assessment is not helpful in diagnosing ADHD.
I had some clients that were not diagnosed as ADHD, even though in sessions it was pretty clear that they might be, because I feel like I'm thinking, like, it come to my mind while you're talking, I'm thinking about 2 or 3 clients that I don't know what's going on with one of them, but one of them was later diagnosed with inattentive type. And because he's not the kid who is like, making a mess in the classroom or have some issues. When I worked with him, when we saw challenges with orthographic processing, and we were like, okay, what is it? And I said to the parents, we have to get him evaluated, because I don't know what it was. What is what? I don't know if it's dyslexia, ADHD, or both. And after a thorough evaluation, he is ADHD inattentive type and dyslexic and dysgraphic and written expression disorder. The thing is with the school, when you apply for an IEP and they do their own assessments, it doesn't really give you a lot of information to the point of, is it ADHD, unless the kid is really like all over the place.
Yeah. Yeah, and we actually let folks know, particularly when folks are calling regarding children and adolescents, that if they're wanting the full neuropsych, that they can also go through their school system. Even if they're in a private school, their district will cover that if they're having academic problems. And sometimes they might do that and then get additional testing if they want to kind of supplement that. Some people would prefer just to go privately, sometimes getting it faster or feeling like there's more confidence. But yeah, they're oftentimes not going to be diagnosing or assessing for ADHD. And that's why, oftentimes I even encourage my clients to talk to the school about, that we're concerned about learning problems, right? Which includes ADHD as well as potential learning disabilities. But oftentimes that will help with the diagnosis process. There's sometimes that people need accommodations, say on the bar exam or the GRE for grad school or the SATs. And in those cases, at times, sometimes there also might need to be testing done, and right, because they oftentimes are asking for data. But, it's also very unclear, because I've heard of different people getting accommodations with just a note from their psychiatrist, while other people have gotten rejected and needed to have the whole IQ test and so on. So it's a bit confusing what folks need. And I actually think that it's quite a broken system, that for folks to get the accommodations that they deserve by law due to their diagnosis, they have to spend, hundreds or thousands of dollars to get the documentation. So one of the things that we do in our Center for ADHD is we try to do a lean assessment if it's very clear from the history, from the clinical interview, also particularly if there's prior testing for an adult. And then from there, we can kind of do the bare minimum to give them the data they need for the accommodations. If it's somebody that's never had a diagnosis, or again, it's a very confusing case, maybe there's, bipolar disorder going on, there's, autism, then we're going to do something more thorough, of course. But when it's that kind of clear-cut situation, oftentimes just helping them with the most efficient, most economical way of getting what they need for their documentation to get their accommodations.
Yeah, I agree with you. It's a broken system, especially when we have. So I would say that most of my caseload specifically is twice exceptional. And so we are working with, so to our listener, twice exceptional is gifted, but but not producing. So this is where the executive functioning has some challenges, and or they have some kind of a learning difference, a learning disability. And what I notice is that, especially with these folks, it's sometimes challenging in the public school to get a 504. Just because they are, they're getting really good grades. So the school is not going to, not always going to give them the 504. Yeah, they get good grades because one, maybe they compensate, or two, they maybe do homework until like 2 a.m. and you have no idea how long it takes them. So they do need those accommodations, because at some point we will see burnout, and then we will see mental health, more for mental health challenges, like you mentioned, anxiety, depression. And I agree with you. This is where the system is definitely broken. And sometimes if there is anxiety and ADHD, this is where I'm like, okay, they're not going to get it through the ADHD. So they just go from the back door, right? Let's go through anxiety, through mental health, and see what we can do with a 504. And this is where we kind of help with accommodation. I'm not an advocate or educational lawyer. But one of the things that we do is that really, we've been doing it for so long that we really kind of understand, and trying to give the parents the language, what to use. And I even sat in a 504 meeting with a client that was many years ago. That was in the Bay Area, in a school, in a high school. The client is definitely gifted, was never diagnosed until 11th grade. And one of the things that I said at the 504, and I was like stunned, because I said there help him advocate. And the teacher said, oh, you have such good grades. So the kid said, what do you want me to fail?
Yeah.
And they still didn't give him the 504.
Yeah, it's such a tough system, right? Because if the kid is achieving, then yeah, they're oftentimes not going to give accommodations for them to, compensate for whatever because they're not seeing it. But I think definitely to that point of, really helping them understand how the person may be overcompensating. I had one person that came to me as a medical student, and they had actually, done well in high school. They went to an Ivy League college. But they said the way I did that was spending twice as much time doing homework and studying than everybody else. And now I'm in med school and there's not enough time. Those compensation strategies were no longer working because there was so much of a demand going on in the school. There wasn't those extra hours to do all that extra studying to compensate. So really kind of understanding if there is compensation that's leading to that. I wanted to mention something because you've mentioned inattentive presentation of ADHD a number of times. And in diagnosing inattentive, that can be very difficult because, as I was mentioning, right, the frontal lobe is the first thing to go when we're not doing well. So particularly, if there's anxiety or the kid's having social problems, or, somebody as an adult is, having difficulty at work, or, they have kids now and they're spread so thin and they're trying to kind of juggle everything. We really kind of need to tease out, is this ADHD or not? When it's more the hyperactivity impulsive, it's pretty clear cut. There's not as many other diagnoses. So one of the things we're always looking for is one, is there a history of ADHD in the family? Because ADHD is highly heritable. Actually, in undergraduate, I worked on a study that looked at twins with ADHD. I was just entering data back then, but it's funny, as things kind of come around, that's a main focus of mine. But Bruce Pennington's work at the University of Denver, and there's been numerous studies on twins with ADHD, and 80% of the time when one child has ADHD, the twin has ADHD, so high heritability. And also, if you've got a child with ADHD, there's a high likelihood you have a parent with ADHD, as well as if you have a parent with ADHD, a high likelihood that you might have a child with ADHD. A lot of times ADHD might not have been diagnosed in the parents. So we're looking for, telltale signs, struggles in school, struggles with employment, any, getting in trouble with the law. Sometimes these things in aunts, uncles, cousins, and really kind of looking if there's any history, because that is going to help us kind of tease out. And then also really with the inattentive, the other thing is that diagnosis between those that are identified as boys versus those identified as girls from birth, that the girls tend to be not diagnosed because their symptomatology tends to be much more on the inattentive side. This is due to some of the XY genes, from my understanding, that the Y gene is, kind of more fragile, where it may have more effects, which is why autism, inattentive, ADHD, hyperactivity symptoms are higher. And there's actually been some research that's found that when they gave a vignette to teachers about a child's symptoms, when they used the pronouns he, they were referred for an assessment for ADHD. When they use the pronouns she, they were referred for an assessment for anxiety.
Mm-hmm.
So these are a number of things that we also have to be looking out for, and especially a number of girls and women with ADHD were not diagnosed because it was more under the radar. It was more that daydreamy, kind of simple mistakes, rather than the behavior problems of more the hyperactive and impulsive. I actually talked on the news about some of the research findings that in the last few years that the diagnosis of ADHD in women has doubled. It's still only 4%, which again, 7% is what, if we're using that 1.5 standard deviation. So there's still a lot of folks that are not diagnosed, but there's been a lot more knowledge, interest in this. TikTok, a lot of people are getting TikTok diagnosis because their algorithms are kind of leading them to it. Which actually there's been a research study where they looked at TikToks about ADHD and actually found about 50% were misinformation. So just another thing for people to be keeping an eye out, and especially after the pandemic, everybody was struggling. And so attention, concentration, focus was really difficult for many people.
Yeah, people don't get evaluated through social media.
Yeah, exactly. I mean, it can be good information. You're like, oh,
yeah,
have some of that, and then check out with somebody, right? And
exactly.
doing a full evaluation to determine if this is or not.
I just want to kind of pinpoint what you said about female. And yes, it's very common. There's a lot of the research was done on males. So this is also why we see late diagnosis. I think most of my caseload most of our clients that come through us, because we do work with adults, we do see a lot of mothers and that were diagnosed because their kid was diagnosed. So I also was diagnosed through my child. So for me, these are especially for women in their 30s and 40s, we see that more. I also have 20 years old girls that are just recently diagnosed. And I think it's also because of masking is a big thing that is going on. But then we see the challenges with task initiation or getting extremely overwhelmed. And then you have this really high anxieties. I also, through my work, I had girls that were not diagnosed with autism. And they were diagnosed with severe anxiety, but not autism. And I remember that was 3 years ago. And we were saying there are too many red flags for autism. Please go ahead and reassess, because she was 16 back then. And the last time she was diagnosed, had an assessment was 10 years ago in a different country. And that showed anxiety and ADHD. And we were like, there are too many other factors that you might want to check. So the good news is that we have more awareness. So that's really, really important.
Yeah. And getting a good diagnosis is so important. And particularly, in one research study, 45% of adults who were self-referred for treatment for ADHD had comorbid anxiety. And so oftentimes people think, oh, well, they've got anxiety. That explains why they have difficulty focusing and attention. But we really, again, have to tease out whether or not those symptoms go all the way back to childhood, those elementary school years, to differentiate, is this kind of more anxiety? Is this more ADHD? Although, teasing that out sometimes can be hard, because if there was anxiety growing up, or if there was complex PTSD,
trauma.
Trauma going on in the house, it can be hard to tease out, is this ADHD or is this trauma? Or even is the trauma potentially related to the parents' ADHD and their emotional reactivity? Because it's also been found to be correlated. So these are kind of things to tease out, to understand. But ultimately, what I talk about is that, for me, it's not going to make a big difference in the treatment approach that I'm going to use. Really, it's going to be whether or not I'm going to refer for a medication evaluation.
Right.
And particularly, even if I determine it's not ADHD, the person can still go for a medication evaluation to determine if medication would be appropriate, because of their current symptoms, which are ADHD symptoms just caused by anxiety or depression or whatever it might be. But in the therapy, particularly for adults, we're going to be using cognitive behavioral therapy, where we're going to be working on time management, organization, managing distractions, all the coaching aspects, as well as all the secondary issues such as anxiety, depression, working with shame, relationship problems, using the cognitive behavioral therapy to really have tools around that. A lot of people don't understand that the therapy for ADHD includes coaching. And actually, if you're working with somebody who says they're working with ADHD and they're not doing the executive functioning, they're probably not an expert in ADHD, because that's such an important part. And really, I've had a lot of people that have also worked with coaches that have been helpful, but sometimes it's not really about, the perfect system of the calendar, the to-do list, or whatever it might be. It's all the things that get in the way, and the anxiety, the avoidance. And, I kind of say it's kind of like, managing weight. Everybody knows you need to eat less or exercise more. On paper, it seems very simple, but there's all these different things that get in the way. Same thing with, folks with ADHD. Everybody knows you're supposed to use a calendar, timers, to-do lists, and so on. But again, it's all the things that get in the way. And so that's where a lot of the work comes in, where the therapist can use the cognitive behavioral therapy work, which is that top-down processing, becoming more aware of our, kind of internalized self-talk. Like, oh, you jerk, you forgot again, you didn't pay that bill, you're so stupid, you're never going to get it.
The guilt trip.
Exactly, and really, like you were saying, being able to bring in that compassionate voice and really kind of help to shift that self-talk. And then also, so that's the top-down processing. And then oftentimes I will use EMDR, or some of the folks in my practice use internal family systems or brain spotting, because sometimes the person can get it like, oh, wait a second, I'm not stupid, and they kind of catch those automatic thoughts, but they're still having that kind of limbic system reactivity. And so that's where those more bottom-up type of treatments really help. And you don't know how many EMDRs I've done with adults where they're sitting in an IAP meeting and got the conclusion that I'm stupid or whatever it might be. And once we process that oftentimes frees up a lot of the shame. Or there's, been a new word in the last several years called rejection sensitivity disorder.
Yes.
Which has been a great way to name it, because again, that's the shame part and the avoidance of rejection, or the doing something where the person's going to fail, and then that confirms that I'm no good. And so, that's the work that we're doing with the adults. And then with the children, the adolescents, a lot of the work is with the family, and helping the family to create structure, to create reinforcement. And that's actually been all the research says the effectiveness. There's not research supporting effectiveness of play therapy with a child with ADHD. That really what we need to do is be able to help create that environment that's going to help support them in being more successful. They're going to feel less depressed, again, feel less shame, less anxiety. And so our work is really with the parents creating structures. And then once we kind of do that, then we oftentimes do a lot of the emotional healing for the kids, and then being able to talk to the parents about, how they felt bad when the parents might yell at them, or when they were feeling stupid in class, and really open that up. That's based on some of Guy Diamond's work, attachment-based family therapy for children and adolescents. Essentially, when you're feeling bad, can you talk to your parents about it? And if not, what gets in the way? And then giving parents tools to draw the kids out, because when they can talk about it, depression, anxiety goes down. And really, we want to create that partnership between the children and the teenagers and their family members to help support them so that they can be successful. And again, right, they're going to mess up 1.5 standard deviations more than the average kid. So how to help them support and learn resiliency to be able to kind of deal with whatever came up, fix the problem, learn from it, and then take the next step in the right direction rather than just kind of spiraling down in shame.
Oh my gosh, you're preaching to the choir. Because even in our work, we do the executive functioning, but we are very different because we are looking on the nervous system.
Mm-hmm.
So we teach our clients we love polyvagal theory, and we love using spoon theory about effort and energy, and understanding that sometimes not sometimes, it's like when we are not regulated, nothing is going to happen. And no matter how old you are, and we all have this moment. And I always said, when you're like driving and somebody is cutting you in a line, and you get pissed, it means your like nervous system is signaling. So I can talk with you for hours, Dr. Sutton. You said like everything that I'm like I believe in, especially with EMDR. And trauma is so big when you're neurodiverse.
Mm-hmm.
So can I ask you one question about EMDR?
Sure,
and for our listeners, EMDR it was for soldiers, a technique to help with post-traumatic stress disorder. But I do have a question about how does it work with somebody who is not on meds and they still need to follow those? Okay, you know what? You need to explain more what EMDR.
Sure,
like very like short version.
Yeah, let me go.
EMDR is a different topic, but it's interesting.
So when there is trauma, whether it be big T trauma, like somebody being in war, assaulted, or little T trauma, getting embarrassed in front of the class or whatever it might be, essentially it's so intense at the time that the person can't process it. So it kind of gets stuck. It's like food that's chewed up but not digested, or like a log jam in the river that's stuck, or like puzzle pieces strewn throughout the mind that aren't put together and filed away in long-term memory. So what ends up happening is we get triggered in the present, and we end up reacting disproportionately in the present because it's triggering that unprocessed stuff. So it's kind of like drilling and then hitting oil. All that emotion just kind of comes gushing out. And so through the EMDR, or there's other approaches, cognitive processing therapy, prolonged exposure, somatic experiencing, all these are basically ways of sitting with and putting those puzzle pieces together. So one of the examples I give is, say, there's a war veteran, they're walking down the street and they hear a firework go off and they jump behind the bush because it's triggering that puzzle piece of the loud bang. They're reacting disproportionately in the present. But after doing the trauma processing, the person's walking along, they hear the firework go off and they go, wait a second, I'm in Palo Alto, I'm not in Iraq, and they don't jump behind the bush. And so particularly with EMDR, originally started with eye movements, and the therapist would move their hand back and forth and the client would follow. And one of the ideas is that it was stimulating the left and right hemisphere of the brain and really kind of putting those verbal and nonverbal puzzle pieces together and filing it away in long-term memory. Another theory is that it actually engages our systems for processing information. So rapid eye movement, which is when we're dreaming and we're processing information, our eyes are moving back and forth in our head. And so one of the ideas is that we're actually affecting that system. I've also do a podcast called Therapy on the Cutting Edge, where I interview different folks doing interesting, innovative work. And I got to interview a neurologist who was doing work where they were looking at what was happening in the brain through EEG during EMDR and seeing that area was being lit up to process. So particularly your question about the eye movement, I actually never learned the eye movement. When I was taught with tapping. And so I use there's these little buzzers that kind of buzz in your hands, one the left, then the right, left, right, or headphones beeping left, right, And so that's actually what I oftentimes use with my clients rather than necessarily the eye movements. And what you can see is the person, their eyes are moving back and forth in their head as you're actually doing the eye movements as they're processing the experience. And yeah, for so many folks, and especially with the adults with ADHD, there are multiple experiences of little t traumas that they've had. And so oftentimes that can get triggered, which is leading to the shame in the present day. And I wanted to connect one piece too that I think is really important for folks to know about the work with children and adolescents. Because you're working with a family and because ADHD is so highly hereditable, if you have it with a kid with ADHD, there's a high likelihood you have a parent with ADHD. And right, structure, consistency ends up having difficulty in creating that structure. But the parent, if there's a parent without ADHD, if there's two parents, sometimes they end up having a hard time because they feel like not only are they managing their kids with ADHD, but they're managing their partner with ADHD, and they've got another kid on their hands. So really needing to know how to work with the kids, with the family, with the couple, and also with the individual adult, and being able to work with the whole system, because somebody might come in, we do work around the kid, things get better, but then we go in to do couples therapy and work on that dynamic to help strengthen that relationship. Or we might start off with an individual adult, do some work, but then, as one of my clients said, he said, oh, I feel like giving up. I've made all these changes. I've been working really hard, but my wife is still treating me like I'm an idiot. There hadn't been that shift in the relationship, even though the management of the symptoms have gotten better. So we moved into couples therapy. Or I've even worked with individuals, couples, and then we ended up working with their family because they had a kid with ADHD and they were really struggling. So really being able to work systemically, I think, is a really important skill for all of those that work with ADHD. And also if you're talking to therapists, if you're a parent, really finding out, does this person also work with the family, or is it just individual therapy with the child? Right. And therapy has been found to be helpful with the depression, the anxiety, behavior problems. But really, we want to help create that functioning family system, because I want to put myself out of a job, and really having the family take over at helping with the emotional support as well as helping the kids with the structure.
This was absolutely what we kind of also telling parents that, your comment about systematic and the entire family that support the individual, and why, and I also tell it to parents. We see the kid this time, this amount. We don't see them, we see them like once or twice a week or 3 times a week.
The parents are there the whole rest of the week.
Exactly. I'm not in the house with you.
Mm-hmm.
I'm not in school with your child. And also having to understand, yes, it's a commitment. Yes, it's a process.
Mm-hmm.
And it's going to take time. And we don't know how long it's going to take, because there are so many underlying processing. And we're not here to fix anybody. We're here to support and to give the tools and the language to help. Even in our line of work, when we are doing, the educational therapy or the executive functioning support, it's really important for us to give the family the language of how to do this.
Mm-hmm. Definitely.
Okay. Any last comments?
No, I think that, we've really covered so much. I think that, you brought up about medication, right? And really how important medication is. We talked about assessment, and really I want people to walk away understanding that good clinical interview is how we diagnose ADHD. So, more than just the 12 minutes with the pediatrician and less than hours and hours with the full neuropsych testing for thousands of dollars. And then, I think the third piece to take away is working with the system, because really, again, doing just the individual work is not going to be as effective as doing the systems work, so that really that work is continuing on after the therapist is gone.
Thank you, Dr. Sutton. It's been a pleasure. We could talk forever, but I know you have a very busy life and work.
Yeah,
All
thanks so
right.
much for having me. I appreciate it. Take care.